read. touches so many people. We've called it the silent killer. And this subject, what I want to say first of all is that I'm aware that a number of people mispronounce, and they call it prostate cancer. And let me establish first of all in the beginning, there are two words. One is prostate, one is prostrate. Prostrate means to fall down, usually to fall down in worship on your face. Prostate is the cancer. But I suppose the two of them have something similar because they both end up potentially with someone lying down. But what I want to do first of all is just read a verse of scripture, and that's 1 Corinthians 6 verses 19 to 20. And it reads thus: What? Know ye not that your body is the temple of the Holy Ghost which is in you, which ye have of God, and ye are not your own? For ye are bought with a price. Therefore glorify your body and in your spirit, which are God's. There are some things that we have control over, some others we don't. But the more we know, the better prepared we can be. And so this afternoon we're going to look at this issue of prostate cancer. I think they were going to show a little video first, but I'm not sure whether they've got it. Oh, right, okay. Well, what we have here today, we're very blessed and privileged to have a doctor with us, not only a doctor, but also a doctor who has had an experience himself. So he's not speaking from theory, he's speaking from personal experience. And his name is Dr. Robert Beardsell. I've known him for many years, and in fact, we went to school together. And not only was he clever in class, but he was pretty good at evading the slipper or the cane. When I'm convinced he was just as guilty as the rest of us who had to bend over and get it. But he was very clever. And what I'd like to do now, because the video's not ready, I'd just like to invite him up to actually say a little something. But we'll just have a little prayer. Eternal Father, we ask that you will guide us today and be with our program, that it may be beneficial to all of us and to someone in particular who needs it. We ask in Jesus' name. Amen. Amen. Yes, Dr. Beardsell, I'd like you, first of all, to just say a little something about why you're interested in this subject and a little something about your personal experience.
Is that switched on? All right. So the reason I'm interested is obviously I've always been interested in the sense of being a doctor. So I've been a family doctor now 35 years. I looked after a practice down in South Manchester in Bredbury, so fairly local. So this is a quick trip for me here, apart from the fact that Mancunian Way was shut, which I didn't know. That's not helped me. So I've obviously looked after a lot of people with prostate cancer, and things have changed a lot over the years. And then I got the cancer myself. So I've gone through everything in terms of screening and the tests and everything else, and come through, had surgery, and fairly recently some radiotherapy. So I've been through the whole thing, and I've learned so much about what we never taught as doctors. We didn't tell people, we didn't really help people. And I think what I'd like to do today is by the end of this, for you all to have a bit more confidence about what it means, what it might mean for you in the future. If you do end up with abnormal tests and having to deal with doctors, I'm hoping I'm going to give you the confidence, because sometimes that is what is necessary. Some doctors are not 100% up to speed with the changes that have happened recently in prostate cancer care. So sometimes you have to know yourself what to ask the doctor for in terms of tests and so on, and hopefully we'll be able to get into that a little bit today if you bear with us. Is that?
Okay, yes. Thank you very much, Dr. Beardsell. I would say that I was hoping there would be more females here as well, because although this is a cancer for men, it does touch females as well. Not in terms of affecting them physically, but there are other issues that we'll deal with as we go through. Yes, what I wanted to ask you first of all was in terms of your experience. Is there something? Why did you want to do this? In terms of what's going on out there that made you think you wanted to do this?
Well, I'm aware of the recent changes, and obviously now, having gone through all the process, I see how difficult it is. And not only that, there's a real importance to the Afro-Caribbean type of community, really. Your risks are higher. So along with me, my risks are higher because my father had prostate cancer, and we'll talk about those hopefully in a minute, all the things that make it more risky. But because it is so important, I thought, let's try. And I have this link. I'm not a practicing Seventh-day Adventist at the moment, but I was brought up that way. I grew up in Africa. My father worked out there as a missionary. I know that's not maybe quite the word it used to be, but obviously we spent a lot of time when I was younger, and I've got great friends.
What part of Africa was that?
That was Tanzania. And Kenya. So I was born in Kenya, actually. So I just feel linked in a way. I know my skin's different, but I feel that way. And so I wanted to see if I could make a difference. So this is our second time that we've done this now.
That's correct. Yes.
And we found the first meeting really quite useful, didn't we? So I thought let's bring it to closer to home for me, because that was Wolverhampton, closer to your place. And I hope you guys are going to find this useful.
Yes. This is our second one. So what I want to do at the very beginning, just say what I'm going to do. I'm going to ask the doctor some questions, and then I'm going to hand him over to you. So if there's any questions in your mind, you need to make sure you remember them, because then there'll be an opening for you as an audience. But first of all, so that it's really clear in our minds, I want to ask you, what is the prostate and what is its function?
Okay, here we go.
I'm glad you're answering and not me.
So the prostate is a gland. So glands are all the things in your body that make something that the body uses. So, for example, the breast is a gland. It makes milk. The prostate gland is a gland. It makes a fluid which keeps the sperm alive. So essentially, sperm, we know, are made in the testicles in the men. But that's the little sperm that are made have to be kept alive. They have to be nurtured. They have to have sugar. They have to have the right acidity and so on. And the prostate gland makes that fluid. So essentially, it's sitting there waiting to be used when we use it.
Do we need would any man prepare to be a model so that we could actually show exactly where it is on the body?
It's okay. I won't show you in detail, but I'll give you an idea.
All right, yeah.
So essentially, we have the bladder, which is sitting quite low down here. And then obviously you've got the tube that brings the urine out. And from the bottom of the bladder, so you can think about it a little bit like, in your bathroom, a fancy bathroom with a nice round hand basin and the waste pipe going out the bottom. So the prostate gland is a bit like the so this is the bottom of the basin, and that's where it's going to go. So this is the bladder, and the water's going to go down there. The gland sort of sits all the way around the tube to the way out. Now that's quite important, as we'll discuss in a minute, when we're talking about the type of symptoms that a diseased prostate is going to give us. So it's sitting around that tube, and if you think about it like a garden hose, if you squeeze the hose, fluid can't come through. So most of the symptoms that we get from a prostate that's going wrong tend to be that the water doesn't want to come away so quickly, it's getting squeezed.
So is that then a sign for a man in terms of him struggling to have a pee, basically?
Yeah, I mean, I think we have to think about the prostate as a silent killer, like you said. The majority of cases of prostate cancer start with no symptoms at all, and so that's why we're going to talk about screening as maybe the way forward. Once the cancer starts to get bigger, then it might give symptoms of squeezing. There is a benign condition, so don't panic too much as we get older.
By benign, what do you mean by benign?
I'm going to come to that. So there's cancer, which is what's dangerous, and then benign, something that's not dangerous. So the benign condition is that every man's prostate gland gets bigger as we get older. So by the time we get to 70, 60, 70, we're all going taking longer to wee when we go to the toilet. It doesn't come out as fast anymore. And that's because the natural swelling, enlargement of that prostate gland is happening. That's not cancer, but it's very common. So that's one not to obviously panic about. What we are worried about as doctors, and something that should concern yourself, is a sudden change. So if you have never had any problems, I've always been able to wee very easily. And then over a period of 3 or 4 weeks or months, suddenly I'm really struggling. That's a real red flag, okay? That's one that you go, tick, I better see the doctor real quick about this.
You hinted earlier that there was something about black men and white men. What's the difference in terms of getting this type of cancer between black men and white men?
Yeah, no, exactly. We don't really know, to be honest. So that's something that they are trying still to do some research on. But
who gets it most and more frequently?
Yeah, so that unfortunately is black men. Considerably more. So let's just get some numbers on this to give us a feeling. 1 in 8 white men will get prostate cancer in their lifetime. So that's about 8 people on that side. 1 of those 8 is going to get cancer if they're white. Right? If you're black, it's 1 in 4. So there's 4 people over here. 1 of those people would be going to get cancer. I know they're all ladies nearly. So that's impossible, but you know what I mean. So it's 1 in 4. That's double the risk for black men compared to the white population. And it's different for example, people from the Far East, Filipinos, they're actually quite a lot, not just Filipinos, just people from the Far East, are lower risk. So they're about 1 in 12 in their lifetime.
Lower risk than white men?
Lower than, yeah, exactly. And then there are other factors probably worth talking about, the risk factors, because they're probably more important than anything when it comes to cancer of the prostate. So there's that risk. And then unfortunately, there's another risk, which is if you have a blood relative, so particularly your father or brother, who has had cancer, prostate cancer, then your risk is 2.5 times higher than just somebody who hasn't got a family history. And unfortunately, these risks they add together. They're not separate. So now we've got somebody who's black, who's got a 1 in 4 risk, who's got a brother who's got it. He's now got a 1 in 2 risk. Right? And if that brings it home to you, how important this meeting is and why we should be full here, really. Yeah. Because it really is important. And obviously, because 1 in 4 people men that are black are going to have prostate cancer, so many of you are going to know somebody in your family who has had it, and that puts your risk up.
Are there any other signs besides intermittent passing of fluid, of urine, things that are more personal?
Yeah, I mean, there are.
Or intimate?
There are. In a way, they're not as important because they're almost too late. We don't want to catch cancers when those things are happening. But yes, if you leave things alone, then obstruction to your blood flow, to your urine flow is the most important. But you can also get blood. So blood in the water can be a sign. It's more often a sign of other things that are important. So blood in the water is always important. Another cancer, bladder cancer, can present that way. So if you ever have blood in the water, you need to see your doctor. But very advanced prostate cancers can present that way. And then another one that can happen is blood in your semen. So after having sex and climaxing, if the fluid has blood in it, then that also needs looking at. So that shouldn't be ignored. So that is something, again, that you're going to need to see a doctor about. And that can, again, be a symptom.
Is there anything...
When I was
in terms of men being able to, as it were, prepare themselves for an intimate moment, being able to, how can we say, rise, as it were.
Okay, yeah. That's not usually a symptom of prostate disease, really. So don't worry about that. And there is help for that, by the way, if you want to go and see a doctor. But what it can be is something that's a side effect of treatments. So if somebody does have prostate cancer and has to go for treatment, then it's not an uncommon result of treatments to have difficulty getting an erection, yeah.
Generally, it's a known unspoken thing that men don't like going to the doctors, and women tend to be more mature about these things, whether it's for themselves or for us. In this sort of situation, we become like little boys and they become the parent. Why is that? Or why do you think it might be?
It's probably got to do with the embarrassment of a personal examination. So obviously, ladies, to some extent, they've kind of accepted that they have to go for their smear tests and they have to when they have children, they have to be examined down below, and so obviously they to some extent are used to it. I don't think they like it, but they know that it has to happen. With men, we think, oh, I'm not sure if I want to be examined. And what we're talking about, of course, there is the doctor making an examination of the back passage. So at that point, you want a doctor with a small finger like me. And basically, it's having a feel inside and seeing, because you can actually feel the prostate gland. Probably the thing to say about that, actually, a lot of people are put off by the thought of having that examination. In 35 years, never examined a gentleman for prostate cancer without symptoms and without some other reason to do it. I tended to put it off, and I managed fine. You don't necessarily have to have your examination. It's useful, it can detect cancer. But if you are against having that done, if you tell your doctor that, he will manage. He will do the blood test. He will find a way around it. It's really nice to have that immediate result, that test, feeling the prostate from a doctor's point of view.
What's the test called? What is that?
PR, we call it. So it's a per-rectal examination.
And the other test that's not physical?
Is the blood test. It's still physical because you need to have a blood test, but it's called a PSA. That's prostate-specific antigen. Shall I explain what that is?
Well, if you're able to do it in plain language.
Yeah, so essentially all the parts inside our body have different shaped proteins, and we can detect a lot of them. So a lot of blood tests are detecting proteins in the bloodstream. Prostate, very interestingly, has a very unique protein that sits on the surface of prostate cells and sometimes gets into the bloodstream. Usually it's when a prostate cell dies or gets pressed on. It releases PSA, so we call it PSA, prostate-specific antigen. So it's something that is only produced in the prostate gland. And that's why we can use it to measure what's happening with the prostate gland. And so we know that if there's a cancer in the prostate gland, that creates more damage in prostate cells. So that damaging prostate cells are releasing more of that protein into the bloodstream. So the PSA test can go up. And that's what doctors measure. PSA test is related to the size of the prostate gland. So as we get older, the PSA test results tend to gradually creep up. What we are looking for as doctors is a sudden rise. So if you've had a PSA test before, for example, that's really useful to us as doctors because we can look back at that one and see, oh, there's been a big jump in that.
So I'm looking around here. I don't remember seeing so many horrified-looking men. I do remember having to go for some kind of test like this, and my shock was when I entered the room, there was a man and a woman in there, and I was thinking, which one of them is going to be doing this? I think the invasiveness of these things do make men very reluctant. But you're saying reluctance is nothing compared to the loss of life.
No, absolutely. And the screening tests we can manage. It's only once you've been detected as having cancer, then obviously suddenly everything ramps up. You do have to go for other tests and so on to prepare you for whatever comes next. And obviously you'll realize at that point they're trying to save your life. So my first appointment at the hospital, when I had a raised PSA test, and they're very quick, the first appointments are within 2 weeks. So you get a high prostate test, you go for an MRI scan now, which is really one of the new things. We might talk more about that if anyone wants to.
What's MRI?
So the Manchester Royal Infirmary was where they started. So we invented the magnetic resonance, I forgot what it is.
Imaging.
Yeah, imaging. That was invented in the Manchester University, so that's one tick for us. And it's a way of imaging very nicely tissue density particularly. So cancer in the prostate is slightly harder and firmer. When I would feel that, I would actually detect it as a lump inside the prostate. It's a lot harder. Well, they can now do that with the MRI scan. So they can interpret the data that's on the scan in terms of density. So they can actually see that's a lot denser than the rest of it. We don't like that. And so they can find really a cancer quite well on an MRI scan now. And it's a very big advance that's been made in the last 5 or 6 years, really. They've got these much more high resolution MRI scans that they can actually, detect the cancers on.
Here's a very, I may see it as an uncomfortable question, but I feel I must ask it. In view of the Tuskegee experiment in the 1940s, where the CDC, the Center for Disease Control in America, they got this black nurse to go to a prison that had black men in it, and gave them the impression that they were getting an injection to help them against sexual disease, when in actual fact, they were being injected with that. So they were used as guinea pigs in order for this study to go forward. And Bill Clinton actually apologized to the remaining black men. I think this was done in 1949, and it was in 2000 before there was an apology from the American government. And during COVID, there were these 2 white doctors in France who were overheard saying, before we test the injections on Europeans, we should test them in Africa. In view of this, could you understand why some black men might be dubious or not trusting the NHS?
Yeah, I mean, obviously those, the history of those types of events, I mean, it's abhorrent to us now, and yeah, absolutely, that history still hangs in the air, doesn't it? I think we can look at what we're talking about today, hopefully a little bit differently, and in the sense that it's for our own personal health. It's something that we're doing, we know, can actually make us avoid something that's life-threatening and live a much longer and more productive life. So I'm hoping it's in a different category, and doctors, we can use them for our own benefit in that sense, rather than them having any opportunity to use us. And once these things are detected, yes, there is some experiences that you'll go through, which obviously I can fill you in, but it might not be the time, which aren't that pleasant. But you have to keep reassuring yourself that actually this is good for me. It's going to save my life. It's what I have to do, I'm afraid.
Okay. Thank you for this part. What I'd like to do now, thank you so much, Dr. Beardsell, is to have this video shown, and then, because the discussion here and the video may bring up other questions in your minds that you want to ask. And after this, then we'll come back up, and then Dr. Beardsell has agreed to be open to question from you guys. Okay. So thank you very much for this part. Thank you. Yes.
Test every year, right? So I did it for about 6 years, and then what happens is your number goes up on the test. And mine went up a little bit, and they said, we want to keep a close eye. So I said, can I have it every 6 months? Then that was for another year and a half, and then they went, it's gone up again. We want to do a MRI. They did an MRI. I then got a call saying you've got a 30% chance it's cancer. And I was like, whoa, well, there's a 70% chance it's not. And they went, yeah, but we want to do a biopsy. So they did a biopsy, and they took samples of my prostate and discovered that I did have cancer, right? And I've been being tested for 8 years, so I caught it early. So my specialist said to me, you will not need treatment at the moment, but you'll need active surveillance, which means I have a blood test every 3 months and an MRI once a year. But here's the thing you need to know. You cannot wait for pain, and you cannot wait for symptoms for prostate cancer. I have prostate cancer, right? I have no pain, I have no symptoms, but I have prostate cancer. But because I know about it, I've caught it early. Now here's the bit you also need to understand, is that gives me the best options for treatment. If you wait, you have less treatment options available, and you have to have it removed, or you have to have radiotherapy. That means you'll live, but you'll have lifestyle problems, right? You'll have erectile dysfunction, and you'll have incontinence. Now, I'm assuming you're a red-blooded male. Do you want to lose your erection? Probably not, right? So if you don't want to lose your erection, what you need to do is do what I just told you. You go to your GP and you say, a friend of mine who was in Batman Begins and The Dark Knight, this actor, right? The voice of the Cube, right? He's done a lot of stuff. He has no symptoms, no pain, and he's under active surveillance because the risk is not pain and symptoms. The risk is your age. And as soon as you are over 45 as a black man, you are at risk. I have 2 brothers who knew nothing about prostate cancer. I told them to get tested 2 years ago. Both of them have now been diagnosed with prostate cancer, and both of them need treatment. I don't need treatment yet. So what I'm saying to you is you need to understand it's known as the silent killer for a reason. There are more people dying from prostate cancer than breast cancer, but breast cancer patients or women are invited for a mammogram. We are not invited for a test for prostate cancer. I'm working on that with a charity. So these are the things to understand. The other thing is, I understand you have a daughter. If a man gets advanced prostate cancer and has a daughter, she is at increased risk of breast and ovarian cancer. Yes, fact. So if you won't do this test for yourself, do it for your daughter, right? I've been saying this to men for over a year now, and a lot of men have rung me up and thanked me because they feel I've saved their life. I hope you're going to listen to me because I'm saving yours, all right? And if you have any more questions, your sister knows who I am. She knows Annie Domingo. She can find me. But trust me, do not wait. Do not wait for pain. Do not wait for symptoms, because by the time you have pain, that means it's spread. Because the cancer's inside your prostate. That's about that big, right? If it stays inside your prostate, you can treat it and cure it. Once it leaves your prostate, it goes into your bones and into your lymph nodes, which means it goes all around your body. You don't want to wait for that. Trust me, black men need to get tested every single year. Go to your GP, say, I deserve a blood test, I have a right to have a blood test, and have it. And if you have any questions, go to the Prostate Cancer website, Prostate Cancer UK. A bit noisy behind me because the cast have come through. But go there, and there's something called a risk check that takes 30 seconds. Put in your age, your family history of cancer, and your ethnicity, and it will tell you what I just told you, that you need to go to your GP and get a blood test. Do it. It will save your life.
Thank you.
There you go.
Okay, so there we have a celebrity who's telling the same story and the same instructions. So what I'd like to do now is to give an opportunity for anyone here who wants to ask the doctor any questions. So we've got a third mic here. So if you want to ask, can you put your hands up? Oh, there's a mic moving there.
Yeah, good afternoon. I'm Martin. I would like to ask the doctor, how effective is it that at times they cannot detect cancer on blood tests?
How effective it is?
Yeah,
The blood test.
on the blood test, yes.
Okay. Yeah, no, it's a really good question because, especially in the past, there's been quite a lot of calling into question how to use the blood test. The problem was that in the past, everybody who had a raised PSA ended up going for further investigations in terms of taking samples from the prostate gland. And the way that was done has changed a little bit recently. The old way really was associated with quite a high risk of getting infections because the biopsy, the sample of the prostate was obtained by going up the back passage and going through the wall of the back passage into the prostate gland and taking a little pinch of prostate cells and then looking at that under the microscope. But making a hole in the back passage was associated with infections, and they've got a new way now where they go more from the side, so it's much cleaner and much easier to do, so it's safer. But probably the more important change recently is the MRI scan. So what we do with your test is we look at it and see, men of your age, what should your test be? Oh, it's a little bit too high for that. So we need to think about whether that could be cancer. So the next stage is to go and have your MRI scan. That's the new thing. That's the thing that's really been a big change in the last few years, is that they don't just send you for your biopsy with a raised PSA test. They think, like you're saying there, how can we trust that? How do we trust that result? So let's do the MRI scan. Now, if you go then for your MRI scan, and the MRI scan shows an area of dense tissue inside the prostate gland that looks like it could be cancerous, then the specialist will plan for you to have the samples taken. And the good thing about that is that they can target quite accurately that area of the prostate gland where the density is higher. Whereas before, they used to do 40 biopsies all over the prostate gland. Now they can just focus in and do a few in the place where the MRI scan is saying there's a problem. And so they can get the samples that will tell us whether it's cancerous or not. So you're quite right. You know, prostate tests on their own aren't really good enough. But added with the other things, examination useful, but it doesn't have to be. MRI more important, and then the next stage is take some little tiny samples and see whether it's cancerous. So that's the whole process really of doing that. And the important thing really, as we're saying there, is you don't have you don't need to have any symptoms. There's one thing that I wanted to probably just cover while I'm thinking about it, and I don't want to miss this. So the way doctors are thinking about prostate testing is changing at the moment. And they've got a new plan which has gone out to you general practitioners, that any man who's of the right age group who asks for a PSA test should get one. That's what your GPs have been told. Right? Now, some GPs haven't realized this yet. So if you go to your GP and you ask for a PSA test and they say, you don't need one, you haven't got any symptoms.
Well, this is something that one or two men have complained about. They've gone to their GP and they've been sort of pushed aside, sort of pushed back like. So that created a perception that, well, the GPs don't care.
Yeah, no, absolutely. And it needs to improve, and I'm hoping...
Is that because it's early? This is a new thing?
Well, yeah, that directive came out about 3 years ago, 2-3 years ago. So it's something that doctors should be aware of. It's very much it's come out from the Department of Health that's what GPs should be doing now, is if a man asks for it, then he can have it. They're not asking yet for you to come in and have a test. They're not going to send for you. Now, the one thing I would say from the video there is a risk checker on the website of Prostate Cancer UK. So this is Prostate Cancer UK. You'll have seen the footballers and managers and all so on wearing one of these. It's cute. You should get yourselves one, because it's important that we think about it. And Prostate Cancer UK does a lot of really good work. There's quite a lot of leaflets I noticed Adrian's got, which are all produced by Prostate Cancer UK, aren't they? So it's a charity. They obviously collect donations, and they use that money very, very well. And they have a risk checker, which within 3 questions, you go on the website, you go to what's called the risk checker, you answer your 3 questions, and it'll tell you whether you're high or low risk. The one thing I'd say about that is that every black man will be high risk. You don't need to do the risk checker. Yeah? Because it's asking you what your ethnicity is, it's asking you whether you've got any family history, and it's asking you your age. Those 3 things are what gives us your risk.
Do you think it's in the media sufficiently? Because when you speak to people, they say they didn't know that. I mean, female issues like breast cancer and other things, they're out there. Would you say generally this is still in its infancy, getting the news out to us?
Yeah, and
it's
also changing still. I mean, that message is what they call it, an interim message. And shall I just talk about the Transform trial?
Could you hold that till the end?
But what it is that we've now realized that the MRI scan and the PSA test together is making it much safer. And in the past, there was just too many men that were going for a biopsy because of a high PSA and didn't need it. So there was damage done to men unnecessarily before. Now it's not like that. So now we're much more into thinking every man should be screened. And I think ultimately it'll come to that.
Okay, thank you. Here's a question. Did you want to?
Yeah, well, I want you done the blood test, and then the results comes out, and you're told to say no. Slightly, your white blood cells are lower. That could be some infection. You need to book after a month for another test. What does that mean?
Yeah, there's this. I've seen this so many times.
Did everyone hear what was asked there? Okay, maybe you could.
So you're saying that the PSA test was slightly high, and the doctor said that there was a white cell count raised, so maybe there may be an infection, and that could cause it. That's what it was, wasn't it?
Yeah, actually, they said the white blood cells were slightly lower.
Yeah.
There could be some infection, and requested for another test in the next 30 days.
Yeah, no, I've seen that a lot of times. What it is, the reason that the doctor does that is because anything that may damage the prostate gland temporarily, like infection, may put your PSA up for a short time. So he's he may be saying, well, maybe your PSA is slightly elevated because you've got an infection, and if we let that settle and then we do another test, it may have come down. It's actually based on a bit of a misconception by doctors. So whether you tell the doctors what I'm going to tell you now is up to you. You can say that I've listened to a doctor and this is what he told me. Essentially, if your PSA is above a certain level and the lab tells us what the level should be for your age. So for me, when I first had a test, I was in my 50s, and up to 2.9 was considered normal for that age group. Mine was 3.1. So that's over it. There's nothing in the advice that tells you the doctor to wait and see if it will settle down. And I've seen that so many times where patients have been told, we'll do it again later and see if it settles down. That's not what the advice to the doctor tells you. The doctor is told that if your test is over that, send you to the specialist within 2 weeks. And that's something that you should insist on. If the doctor says, oh yeah, you're over the target for your age group, don't let him say, we'll wait 6 weeks. You tell him, no, I want to be referred to the specialist now, because the specialist will do an MRI scan, and that's a better test. So you'll get the next stage of it. You may as well go and have your MRI scan. Yes, it costs the NHS. I'm not bothered about that. I'm worried about my health. So I'll go and have my MRI scan and see whether that shows up anything. Because if it does, then obviously the first test was right. It's too high. And while you're waiting for all that to happen, you can have another PSA test down the line, can't you? And see if it settles down.
I think this gentleman here was all right, okay.
My name is Blackson, and I've got 2 questions. The first one is, if truly, as black people, we are 4 times at risk than our counterpart, the white men, my question is, why aren't we asked to test at an early stage before waiting for ourselves to come around? We thank God for men like you who are now giving us this awareness. Probably without such type of an awareness, many of us will still remain in darkness, ignorant. And following that, is there a suggestion of some noise we need to make for the government to wake up and start screening us?
Yeah, I mean, you make a good point there. This change that I'm talking about, which is happening, will solve the problem. Because I'm sure, can I talk about the Transform trial yet? I'm sure that what they're doing at the moment will give us a very good way of screening, and then everybody will be asked to come in. The way that they're leaving it at the moment is that we have to ask for it ourselves, and that's why I think this is so important. And every black man over the age of 45 should have his test every year, like the video was saying. And the only way that's going to happen at the moment is if you ask for it, if you actually make the appointment with the GPs and actually have it done. That will change soon. Now, when I say soon in medicine is often several years, because they're planning to do a trial of the best way to screen. And we may talk about it later if we've got time. but that's all being organised by Prostate Cancer UK, and there is funding from the Department of Health as well. And they're going to do a massive trial, 300,000 men ultimately, who are going to be watched, scanned, PSA tested, and also genetic testing. So this may give other answers. We're not quite sure what that will throw up, whether it will actually give some answer as to why there's a difference in the risk for black men. But it's something that obviously takes time. When they're setting it all up at the moment, and ultimately then they have to ask the men to come in and follow them through for several years. So the in-between stage, before that all gets decided, they're leaving it like I've just explained to you. Just go and ask them, and they must say yes. If they don't, you kick up a rumpus about it and say, no, you need to go and check your advice from the Department of Health. You have to give me a test if I ask for one and I'm over 45. You know, the only thing they could deny it is if you're under 45. But even there, if you're high risk, and there are other reasons why we can be at higher risk. If we have a family history where a mother or a sister has breast cancer or ovarian cancer, it increases our risk even more. So if you have those risks, then you're entitled to ask for a PSA test at the age of 40.
Did you have a second question, sir? Or has it been answered in this? Okay, thank you. Now over this side, Jim.
Just want to tie in with an experience I had with a question at the end, please, Dr. Beardsell. Right, at the age of 61, a couple of years ago, I mean, I drink around 4 pints of water a day, but I found I was passing water a lot. No pain or anything. Went to see my GP, and he did the fingers up the rectum. Yeah, he said, you've got a slightly enlarged prostate. Now, around that time, I always have a full annual blood count done, yeah? It picked up that there was microscopic blood in the water, you know, that you can't see to the naked eye. So my GP said, it's coming from somewhere around, maybe near the kidneys, down to the bladder, but he doesn't know where. But he said, what we'll do is we'll send you for a scan at Wythenshawe Hospital. So I went down there, and I think that was fairly inconclusive. And then I got a letter from the doctors saying that they're going to send me for a cytoscopy. Yeah? And okay, that was quite a way ahead. And then I remember I was doing some gardening work for a client, and got a phone call when I was up the ladders with clippers. Can you come in tomorrow? 7 o'clock, Withington Day Hospital. I said, yeah, sure, no problem. Got there, an advanced nurse practitioner came in and asked me a load of questions, yeah, and she was a bit annoyed that the surgery hadn't done a PSA test, you know, and she took a load of information from me, and then she said, right, I thought she'd be taking me through to a male doctor, but she said, no, I'll be doing it. And I went in, and there was 3 young ladies, students, they were watching in attendance. But you know something, I'd say to anybody in a situation like this, you just have to bite the bullet as a man. Don't be embarrassed, because it's a very serious matter. So she put the camera up my manhood, as you know the cytoscopy is, and then she said she couldn't see anything sort of any concern. Like, she had a good look round. Then she said, well, you'll speak to the consultant shortly at the hospital. He called me in. He said, for your age, you've got, is it benign prostate hyperplasia, whatever it's called. He said, your PSA level is normal for your age.
Well, do you know benign prostate hyperplasia? Are you able to explain that, or can you explain that?
I'll let Dr. Beardsell explain it.
Okay.
The question was going to, I just want to give an experience. It's, I presume it's standard, isn't it? If they find water, even if it's microscopic blood in your water, Is it normally, would they do a cytoscopy first, then a scan, or the reverse?
Yeah, I mean, either really. If you've got blood in the water, they usually do the cystoscopy first. So that's having a good look around, because there are things inside the bladder that could bleed, and they need to look for where it may be coming from. And if that's negative, they'd probably do a kidney scan following that, I would have thought.
Yeah, I had the kidney scan, and when I went to see the consultant, he said it's a bit strange that you didn't have the cytoscopy first, but he said, as he was walking me out the door, been busy, you know, he said, you've not got blood cancer, you've not got prostate cancer. He said, your PSA level is normal for a man your age.
Yeah.
I can't remember what it was. I think it might have been 3.2, I'm not sure, I can't remember, but he said it's normal
At
range.
61,
but I've not,
it probably would be that,
to
actually.
my knowledge, I've not been tested since, but I'm thinking, I would ask you a question. If I go back next year, do you think it's sensible maybe just to ask for a PSA test each year?
Yeah, I mean, you could ask that from your GP. There's no reason why you can't have that. And nowadays, remember, if you have the NHS app, you get the result back on your app, so you can actually look at it yourself. And it does actually give you the normal range for the test, so that you can actually see whether it's above what it should be. Just filling you in with the benign prostatic hypertrophy, that's what I was mentioning before, that happens as we get older. Our prostate glands, they all get a little bit bigger with time. And obviously, at some point, that can become a physical obstruction. Sometimes it can get so big that it needs to be dealt with by an operation, sort of to open it up. But by and large, there are things that you can take to shrink it and to keep it smaller. So if you keep up with your treatment, you should be okay.
Yes, it's not something we speak about much, you know, in a public place when men go into the urinals and everything. Sometimes you go in and, you know, do what you have to do, and you see some guy over here just taking ages and ages and ages. And I mean, before, when I knew less, I thought it was hilarious, but maybe there were signs that he wasn't aware of.
One advantage of having had the operation to remove my prostate is that went away. I'm back to normal from that point of view.
A horse, yes.
There was something I thought of then.
If anything comes to you, you want to write it down. Thank you very much, Jim. Is there a question over here? Yes, sir. There's the mic. And then there's one more over here as well.
Sorry, I'm not very good to speak English, but I think you understand me what I want to speak. I have 52 years old. I never been to hospital doing the analysis of my body. I don't know what I have inside up to now. I want to ask about if it's very important to doing the test of prostate. Is very important or not? Maybe somebody thinking, I'm not going to do the test. What happens if not doing the test? If we have the prostate pain or not pain?
No, it tends not to be painful. It tends not to give symptoms at the beginning. I've sort of never had any symptoms, apart from, you know, very slight slowing down of the waterworks, but I never had any symptoms, no pain, no nothing. And that it is important for a white person from the age of 50, I think, to have a PSA every year. That's the only way you know that you're okay. It's the only guide we have. We've talked about it maybe not being quite such a good test, but it's the only test at the minute that is easy to do and we can get freely from our doctors. So I would suggest that you see the doctor and have a test every year, definitely. And as I mentioned before, for the black men, from the age of 45 every year. And it's quite useful, it's from a doctor's point of view, to have a test every year, because I can look at that and see, okay, well, that's just creeped up a little bit, then it's the same, then it's crept up a bit, then it's the same, and then it went boom. Whoa, that's not good. So changes in the PSA test is really rapid changes are something that doctors are looking for. So if I've not got a previous test to look at, I don't have that advantage when I do looking at a test. So yes, have it every year if you can.
Yes, this sister over here.
Yeah, a couple of questions if I can. First of all, on Jim's point, if you go into a room and there's students or people who are superfluous to the actual procedure, you can ask them to leave. You don't have to, be there as an exhibit. They should ask you.
That's a very important point that as generally we're not aware of. We didn't know that, right?
Yeah, you don't have to have people observe. They should be asking you, is it okay if these students watch? And you have the option. But if they don't ask you the question, you can still tell them, actually, I prefer if you just did the examination without.
Thank you very much for that. Thank you.
But my question was about BPH and how common that is in black males, and does that cause your PSA to rise?
Yeah, it causes the gradual rise that I've talked about. So every year, if you had one, it might go up a 0.1, and then it would go up another 0.1 next year. That kind of steady slope of a rise is what is okay. So we're okay with that. And that's why it's useful to have it every year. Benign prostatic hypertrophy, it's really an occupational hazard of being male. We all will get it at some stage, it's just when. So it may happen when we're 80, it might happen when we're 60, but we're going to get it at some stage. So yeah, it's very common.
And finally, sorry, just one more point, one more question. Are you going to talk about what we can do to prevent? Because we know we're high risk, or males are high risk, but an ounce of prevention is better than a pound of cure. So are there any things that we can do, lifestyle or dietary, that can help?
Yeah, it's a difficult one, because in this case of cancer, there isn't actually any prevention that's any use. There's obviously lots of cancers where that is the case. Lungs, don't smoke, etc., etc. Skin, don't go in the sun. But for prostate, it doesn't, we haven't actually found a single modifiable risk. I think it's important to look after your health generally for lots of other reasons. But no, we haven't actually found anything which you can modify that will change that risk.
So you could be a juicing vegetarian the whole time. There's not much difference between your prospects and the prospects of a meat eater or something like that.
Not at all. And this is where there's a little bit of confusion, because there are some dietary things that can be done for BPH. So for the benign prostatic hypertrophy, you can actually modify that by certainly taking medications, and there are some dietary suggestions that do help it. But that does not, that's a separate thing to cancer, the prostate. There's nothing that modifies your risk. You're born with your risk, and that's it. I say that. There is one thing which makes a difference, but it's not your risk of having cancer. So the risk of cancer stays the same. But people that are overweight, there was a study that showed that if men are overweight, they're more likely to present with an advanced cancer. And I've not seen that explained. It could easily be that for some reason just being overweight makes men less likely to present to their doctors, for example, because when they do present, they tend to have a much more aggressive cancer.
So is body mass index an important thing to do for men who...
Always, for everybody, but Not so much for prostate cancer, just for health, yeah.
Right.
But there is a suggestion, because I just wanted to be complete. Actually, there's one thing really important that I missed, which I want to mention, because it is important. And it's not, I'm not saying it to scare you, just to, again, to show you how important that this is. Black men have higher risk of having cancer, but they also have a higher risk of presenting younger.
Is that with
than white
cancers in
people.
general, or
no,
or
prostate cancer
prostate?
I'm talking about. So it's one of the reasons why you really must go at 45. If you're anywhere near 45, go and get your PSA if you've not had it yet. Because if you present younger with a more aggressive cancer, then you're much more likely to die of your cancer. And I can give you the numbers if you want, but you know, that's probably scary enough, is it?
That's a warning. Before this, brother, did you have a question here? Because I'm sure I saw your hand. Okay, no worries. Then this brother with a microphone, and then we'll swing over here and then come back to this side.
Hi, Dr. I'm Keith.
Hi.
I just want to link back to one of the points you made before with regards to the MRI scan. I take it, or just gain some clarity really, I assume that if your PSA level is at a high level, then if it trips over what's appropriate for your age group, then you can go for an MRI scan. I'm just wondering whether we can just skip the PSA test and just go straight to MRI, or is that cost?
Yeah, at the minute that's cost. You probably wouldn't get that on the NHS without a raised PSA. But it's coming in. Remember what I was saying, that that screening will happen. And I'm fairly sure that the screening will include MRI screening. They're increasing the number of MRI scanners, the sort of high definition scanners. And they are hoping to get to a point when this trial finally reports, hopefully showing that it is the right way to screen, then the screening will be, may actually just be an MRI scan. We're not sure yet. If that trial shows that the MRI scans are okay on their own, you might not even have PSA involved. We're not sure about that. That's what they're trying to work out.
How far away are we from getting to that level? You know, same with trialing. Is it months or years?
It's years. I'm actually going to talk to one of the doctors that's involved in it. I'm sort of offering to sort of help out with some of it, if I can. Now that I'm retired and I've got something else, you know, I kind of looking for other things to do that are useful. So they're doing what's called phase 1 at the moment. The phase 1 is going to be, I think, 18,000 men. They're hoping to recruit of that.
Is this the Transform?
Yeah. They're hoping to recruit 15%, I think it was. It's either 10 or 15 of black men, because obviously it's really important that there's a high enough proportion in that trial, because your data is so important.
Can you volunteer for it, or is it just
I'm at the minute, that isn't going to happen, but that's one of the things that I'm personally going to suggest. That it's actually going to be more difficult if they just open it up to GPs. Because what they're planning at the minute is that GPs will be asked to find men in the right age group, send them a letter and invite them into the trial. But is that going to get the proportion of black men that we really need? I mean, I would like to see that proportion as high as possible, because it's so important. It's more, your data is probably more important than all the rest of it.
Can I just mention another? Chair,
Go ahead.
Can I? Yeah, it's all right. I have an enlarged prostate, and there's different tablets that I've been prescribed. Tamsulosin is one of them, because I often went to the toilet. But then I'm on finasteride.
Finasteride, yeah.
But I think that's more used to reduce the size of the prostate.
Yeah.
Now, for those who may have similar symptoms, there are different tablets that you can go on. In terms of sort of side effects, and you probably answered my question around any sort of natural remedies, but it doesn't seem as though there is much. Is there anything else which could help reduce the size of the prostate?
Medication-wise?
Yeah.
Or, yeah, there are one or two, so that it might be worth that you go back and ask for a swap. I mean, there are things said to work, beetroot and this and that, but I don't think it works that well, to be honest. So tablets are much more effective.
Before we come over here, was there someone over here who wanted to ask? Oh, I see. Okay, I'll hold fire. Go ahead, sir.
Hello, everyone. My name is Kirit. I work for a cancer support organisation called Can Survive UK. I'm very pleased to be here and very good to hear yourself, Doctor, about the experiences of cancer and prostate cancer in particular.
Could you just hold the mic?
Oh, sorry, yeah. I just want to just talk about our charity, but invite everybody to get involved with our charity. Our charity is called Can Survive UK. We're a charity focused on cancer and the impact of cancer within Black and minority communities across Greater Manchester. We've got cancer support groups starting already established in Salford, in Manchester, Trafford, Tameside, and in Oldham. And we've got a beginning of one in the autumn in Salford. And our intention is to bring people together from our Black and African Asian communities together and have a space to meet and talk. And I think one of the things that comes from this conversation is the barriers to a conversation. So there's a fear, there's a stigma, and the discrimination that cancer presents. And this, we're glad that we're within a religious setting, because there's spirituality, people have fears, and there's different answers to why we have cancer within our communities. And what we need to do is to talk. We need to come up, and we need to speak up, and we need to be in a place of compassion and care.
How can we be aware of when you say these meetings are being created? How can we be aware of when they are? Because there may be some who may want to
this is it. We're just a very, very small charity. You know, I mean, there's 5 of us. There's 2 full-time workers and 3 part-time workers. But we have sessional workers and we have volunteers. And what we want to do and encourage is get everybody to become involved. And whatever that involvement looks like, it could be 1 hour, it could be an hour, it could be whatever you are able to offer and support, because I think this is not just about a personal story. My own personally, my father-in-law passed away from prostate cancer. He was in his 60s when he found out, and he was silent for a year. He had blood in his urine, and he didn't talk about it, and he didn't tell anyone, and sadly we've lost him. But that's a personal experience of where talking doesn't, we don't talk about it, and the fear of not talking about it, because I think the challenge for men is that they think they're burdening. They think that by sharing, that they're actually adding weight. And, do you know what I mean? It's about protection. It's a feeling of being a man and being in charge. And
my question is connected directly to this, and I want to ask you, there are women here. Some may have husbands or brothers or daddies who have nothing to do, have to be dragged kicking and screaming to the GPs. What would you advise women to do?
Well, I think this is a good point. I think women, as you said earlier, they're socialized into talking, socialized into going to health settings, socialized to meet their doctors and nurses and so on. And men aren't. But they would listen to their partners. They will talk to their loved ones, and they will begrudgingly, they will find a way. And I think this is the joy of women, of having that conversation, that comforting way of saying this needs to be seen, and I will go with you, and make that appointment, go along, and be that kind of support, that emotional and practical support, handhold them and drag them. I don't know what it requires, but it requires a bit of maneuvering. Use your ways and your approaches that will work, and the men in your life, what will work and what won't work. And that's the thing. But I think we as men, I think one example is there are examples of men's groups, which are like Men in Sheds, for example. It's about doing and not talking, okay? So if the answer is through the doing, so the Men in Shed example in Stockport is that they use bikes, they recycle bikes, and through the recycling the bikes, what they're doing is they're looking at their mental health and they're talking. And what I'm saying is that we've got to find a way of talking about the things that matter, and find a way to talk about the things that will change, not just you, but your lives, your children's lives, And just bear in mind that just think about the missing chair in your life, the missing chair around the table. And I'm telling you, this is such a painful experience. It's such a painful experience. And this can all be avoided because, as the doctor really defined it, there are different ways to look at prostate cancer. The finger is not the only answer. There are other approaches and other answers. I think that is one of the ways. So that's the health medical side. But look at the social side. You know, how do we as communities, as churches, as gurdwaras, as mosques, as mandirs, how do we talk about cancer in a way that is a conversation and not leave it? Even though God gives us so much, God also gives us reasons to live. The advances, the treatments that the doctor described, we've moved on. It's like 6 years on, and things have changed already, and there's this program and this progress. So I won't speak anymore because I'm conscious I talk a lot. So lovely to meet you all, and please do get involved with our work and our charity. And I look forward to being part of your church and your involvement. So if you invite me back, hopefully.
Thank you so much. Thank you. Really appreciate it.
Right, so this question came from Zoom, and it's been established that prostate cancer is more prevalent amongst black men. So this fellow is asking, does the environment...
Can everyone hear over here?
Can we hear? All right, so maybe I should just stand up then. So the question came from Zoom, and someone is asking to say, does the environment or socioeconomic factors contribute to the high number of men having prostate cancer? Does our environment or socioeconomic factors, are they a risk?
When you say the high number of men, do you mean the high number of black men?
Black men having,
All right.
prostate cancer amongst black men now.
Yeah, I mean, this goes back to what I was saying before, really, is that there aren't any modifiable factors involved. The main factors involved are genetics. So either being Afro-Caribbean genetic extraction, or being somebody whose brother or father has had prostate cancer, or mother or sister has had ovarian or breast cancer. So it's all those kind of things rather than environmental. We haven't found any environmental risk. And in fact, if you look at the risks, for example, of black men, whether they grew up in Africa or whether they grew up here or America or the Caribbean, the risks are the same. Very, very similar risks. So we don't think it does make a difference.
Oh, so there's not really a demographic issue, it's genetic.
Yeah.
Okay, thank you. I think there's one here, and then over here in the centre, and then I think, are there any more after that that are? Okay, we'll make these. We'll summarise after this.
Yeah.
Okay, if you can take that on, Donald. Yeah, great.
Okay, mine is more like, it's a question, but it comes from the background of being African, black African. I just recently moved to UK, and that's when I started getting more of the awareness of the prostate cancer thing. But back home, it is believed that prostate cancer only happens to those who have ceased to be sexually active. That's why it's said mostly above 45 and above, because most of men in those ages up, they become less active. So can you please help us and decipher this myth? Because I know it's a myth, there's no scientific evidence about it, but it's what most black men believe in Africa.
Yeah. Hello? Sorry, I just swapped the mic, so just checking it worked. Yeah, I'm African as well. Sort of. No, they've got it wrong, I'm afraid. It is absolutely clear. They have done quite a lot of research on this. And it's interesting that men that are sexually active have a slightly lower risk of having prostate cancer in their life. So it's exactly the opposite, really, of what they're believing there. There are obviously other things that happen, you know, that can go wrong, infections and all that sort of stuff. It's not good, but it doesn't increase your risk of prostate cancer, I'm afraid.
Thank you. Now we're in the center as we move across. We'll take the two in the center and then move across to this side. Go ahead, sir.
Yeah, thank you. I have this question that I would want you to clarify. You know, like what my brother said, in Africa, there's this myth that once you're diagnosed with cancer, then you're gone, you cannot survive. What's the survival rate in the early stage cancer and the advanced cancer stage?
Sorry, just clarify what you said there. So is there a difference between clarify the difference between early and late?
Yeah, because what it is like, where we're coming from in Africa, we told to say once you've cancer, then that's the end of your life. If you've wealth, you just have to start, sharing among your relatives. So I want to know whether it's something that I can survive if I have cancer.
So early detection obviously is good, because if it's not yet spread out of the prostate gland, then it can be removed completely, and that means that you have no risk for the rest of your life. You're free and clear. Survival rates of early cancer are 95% survival for early detection. So there's a small number that will later on get problems that weren't spotted at the beginning. But that's brilliant. That means 19 out of 20 men with early cancer will survive. If you wait till the cancer's spread, particularly if it's spread to spine or somewhere different to the prostate gland, then the survival rate for 10 years goes down to 45%. So it's still not terrible. It means, nearly half the people with that really bad cancer will survive 10 years. There's a lot of treatments that can be given to slow even the worst cancers. We're talking, remember, everything I say is about prostate cancer, yeah? So there are a lot of treatments that can slow down the progress of it. So if you're unlucky, like for example, I was unlucky, I had my prostate removed, and then what we do is we check your PSA test. Your PSA test should go to 0, because now I've got no prostate, it's all gone. So my PSA test should be 0, but it didn't. So I'm unlucky. The majority of people that have surgery because the cancer's in the prostate gland will get rid of it. But there's a small proportion who won't get rid of it, so that was me. So I went, just finished a month ago, some radiotherapy for a month at the Churchthe. So I had to go there every day. Completely pain-free, just go in on the machine, a little bit like the scan machine. You lie there, it goes zap, you don't even feel it, you go home. But you do that every day for a month, so it was a bit of a long month. So hopefully that will kill now any cells that had sneaked out and that had spread. So that's the plan. So now I'm in a situation where I now wait and see. But if it comes back, I'm not done. That's not the end of me, because there are other treatments. So there's a treatment where they take away all hormones. So you have to have an injection or tablets that will take away the male hormones. It has some side effects, but it stops the prostate growing. So even the worst cancers who can't be operated on can have that sort of treatment and mean that at least half of them will still be doing quite well after 10 years. Does that answer?
Thank you. Herma, and then over this side. Go ahead.
Okay. I just want to know what is the difference from other nations. What are they doing different from what Africans are doing? That, you know, that could encourage a black person from not doing it then, you know. What is the white folks are doing to prevent so that, you know, they could learn from that and change? And also, is it true that cancer can be treated if you do not feed it with acid environments?
Yeah, it's the natural thing with cancers generally to think about, is there a way of preventing it? Is there a way of stopping it happening in the first place? That's one of the unique things about prostate cancer is we can't find anything that we can say, if you don't do that, you'll have less cancer. So when you were asking me, is there something different that African people maybe do that that white people in this country don't do, or do to sort of change the proportion of cancers? There actually isn't anything. We can't so far detect anything, and quite a lot of research has been done to try and find out whether there's ways of preventing it, whether there's changes in lifestyle, whether there's anything that we can do. And with prostate cancer, there does not seem to be anything that's linked. I don't know if that helps.
Right, I've got a question as well. I don't know whether you are aware about the sampling procedure that was used, where the sample of men, like African men, who were tested, picked up from right here in Europe, or you did get some samples also from Africans in their natural environment, where they've been eating their natural food and natural environment. Yeah, that's my first question. And the second question is, unfortunately, we couldn't get any diagram here, but when you explained, you said the prostate gland is just below the bladder, right? But how does it transfer now to enlarge the testicle? Because you find the testicle becomes enlarged. I don't know how does it transfer there. Thank you.
I didn't catch the second question very well. If we do the first one, maybe.
Deal with the first question. Can you say it again for the benefit of everybody? The first question, then the doctor will answer, and then we'll deal with the second.
The first question was the first question about was about the sampling procedure. The sample of people who were tested, were they from here in Europe, or else you also tested people, say, from Africa in their natural environment?
All right, I understand that one. Yeah, no, it wasn't actually a test. The statistics on cancer is more just picking up the end point, which is how many people were diagnosed with cancer and how many died. It's not that there hasn't been a trial in Africa, for example, where people were recruited and watched. It's really just looking at the diagnoses. And when you look at the numbers of people and you try and make sure that the conditions are the same age, same everything, and compare with black people, for example, that have grown up and lived here, or white people for that matter, they're just looking at the incidence. So it's how many cancers happened, and it's the same. So what that makes us think, whether it's true or not, but it probably is that because the incidence is always the same for black men, wherever they are, however they lived, then really it doesn't look like there's anything that influences it. And what the second question?
So that means whether they lived in Africa or whether they live here, there were no changes, nothing that really influenced it.
Yeah, and there's not really been a trial, because I think he was asking whether there'd ever been a proper trial done, identifying the difference between Africans and people that grew up in Africa, yeah? That's what you were asking, to try and see if there's a difference. No, that's never been done, but they just look at the total number of people having cancer, the total number of black men of that age group, and then is it the same? Your second?
My second question was, how does the prostate gland enlargement transfers to make the testicle grow bigger as well?
I'm not sure that happens, does it? Prostate gland gets bigger. Generally speaking, men's testicles will get smaller with age. So it's kind of an opposite relationship. I don't think they're linked, really. Hormone, they've done quite a lot of research on hormone levels to see, because that was something that was thought, could the amount of male hormone in the body maybe influence the incidence of prostate cancer, and they never were able to prove that. It doesn't seem to matter whether you've got a lot of testosterone or a little bit of testosterone through your life. It doesn't affect your incidence of prostate cancer.
My point was really about access to imaging. I think it was mentioned earlier on that if you have a raised PSA, you should be referred for an MRI scan. And I just wanted to make the point that it's not always that easy to get a referral for MRI, and because of the waiting lists and things like that. And I think it's still a little bit of a problem. Just to clarify, I'm a radiographer, so I've done some of the MRI imaging. Don't do them anymore. I do the PET and the oncology imaging. So it's not always easy to get the MRI scans.
It's my understanding. I mean, you may know more about this than I do, but certainly in Stockport area, and Stockport's one of the big urology departments, is that they're now linked to 2-week wait referrals. So if your GP, if you go to see your GP and you have a raised PSA and it's above the threshold, then you get referred on the 2-week wait to the urology. And what Stepping Hill does is an MRI scan before you see the consultant, which is nice because now when the consultant sees you, they've already got the MRI scan. And it changed about 2 years ago. I was one of the ones who got to the specialist and they said, "Oh, haven't you had your MRI scan yet?" And I was having it the next day. So they've always, in the last sort of 5 or 6 years in Stockport, at least tried to get the MRI scans done quickly. But now they've set the clinic up so that you have your MRI scan before you see the specialist. I can't speak obviously for other parts of Manchester. I would hope that they'll all be catching up with that though.
Yeah, probably things are improving, but certainly Stepping Hill is a good place a good catchment area, but other places sometimes you have to push a little bit harder to get it, because I think, I know I'm going back a few years, I've had a family member who had prostate cancer. I had to really push to get the MRI scan. They were going to fob him off with a CT, which wasn't going to show any spread and wasn't going to do anything outside of the prostate gland. So sometimes you have to push a little bit.
So you're talking about pushing, and this gentleman here set up an organization. Do you think if anyone is struggling to get into the system, would they be wise to seek you out at all? Oh, hold on. We need a mic here.
Can you hear me? Yeah, okay, great. Yeah, so Cancer Survive UK was set up because Marcella Turner was from a Jamaican background. Her parents, she lost both her parents to cancer, to bowel cancer, prostate cancer. And that set her to recognize that when they were at that point where her family needed support and care within the National Health Service, they had a lot of good, incredible support, but there were areas where they were lacking. And that's where she felt the need and the urgency of it to do something about it. And she approached lots of people around the time to get involved, and I was one of the people that she asked and approached. So the work for us is to to do three things. First of all, is to bring people together and find support in each other and come together weekly, fortnightly, monthly, and provide that initial first-hand support for people from their own background, from their own communities. That's the first bit. Second bit is that they have access to us and to our contacts, and with our own support, we will handhold and take them to those places, talk to the GPs, if we can get access to them. But, we find a way and a road in, because we are a trusted organization, because we developed this time over 9 years. We are into our 10th year next year.
So do you have, because this is really important what the sister was saying, do you have a website or a card or something?
We have a website called Can Survive. It's very simple, can-survive.org.uk. And I'm here anyway, so you can come and talk to me. I'm here today, and I'm going to continue to come here as long as you need me to help and support you.
Bless you. Thank you very much, sir.
Right. Thank you. Thanks so much.
Thank you for that question.
Just on while we're getting the microphone, the Prostate Cancer UK website has so much good information on it, and I think they also have ways of contacting, and you can ask them if they're specialist nurses if you're having problems, and they do all sorts of good things like. When I had my surgery, my wife requested a pack which gave lots of things like pads and things that you might need. So there's a lot of good stuff on there, and there's a lot of good stuff for doctors as well. I mean, they've got all the research papers and so on are all in there. It's quite good. So you can spend any time you're interested in finding out more about the prostate cancer. That website, the Prostate Cancer UK website, has a lot of good stuff on it.
Thank you. Yes, sir. And then you. Before you say, did you say that? Oh, I'm sorry. Yes, as well. Yes. So once, are these questions now, or are these the experiences? All right. Go ahead. Yes.
Yeah. Hello. 1 2 1 2 1 2. I'm going now. I'm going. My
Sorry.
Oh, we got two doing. There's a duet here.
Okay. Sorry, I'll allow you to go. Let me just ask. My question is quick. I've come late, but I'm not too sure whether somebody has asked this question. What impact does exercise have on the prostate? Is there any benefit or is there any impact that's positive when it comes to exercise in terms of prevention? And is it possible to actually massage as well, the prostate?
Yeah, again, there is no link between exercise, either improvement or negative in terms of the cancer incidence. It can cause problems if you're not careful in terms of putting a PSA test up. So if, for example, you've been on a long bicycle ride, there's a lot of pressure on the prostate gland. And that can actually be something that puts up a PSA test. So it's probably recommended that if you're going to have a PSA test, you haven't had any long bike rides in the previous 3 or 4 days. But the exercise, which is great, how good is it for your body? But it doesn't actually change the incidence of prostate cancer.
Yeah, I mean, that's a very important point there, because if people are exercising under the belief that it does help them, then I suppose psychologically it can be quite disappointing if they find it doesn't help, because exercise is so useful for so many other elements of life.
I would hope. Exercising should never be a disappointment for anyone. I mean, it's so good for us. It's so good for so many different things, including people with bad joints like me. I'm going for my surgery on Friday. I'm still going for walks to have my ankle replaced. But it's still good for you, great for you. So keep exercising, please.
Yes, sir.
I think my question has been answered along the way as I've been listening to your answers. I think I would just ask the question in case those who are giving the testimonies may want to, maybe the people to answer that. My question was, I'm thinking I'm at a time where they have probably told me that now I have this cancer. What happens to me after that? What process do I go through?
Right. So, in general, the first thing obviously is to try and work out how extensive the cancer is, and also how aggressive the cancer is. So cancer can come in, when they look at it under a microscope, they're looking at the little cells, cancer cells, and prostate cells can look normal, they can look a bit bigger, then they can look a bit raggedy, and then they start calling them precancerous. Then they can look cancerous, where the dark bit inside the cell starts to look raggedy. So there's all different things that they can look at, and they know that the ones that are the worst looking cells will spread quicker. So they want to look at them and decide how many bad cells you've got and how many that aren't so bad, and see what the proportion is. And they give a score out of 10, and anything that's 7 or above, you're going to need some treatment for your cancer. And then you usually talk to a surgeon first about whether, first of all, surgery is an option, because sometimes they'll decide surgery is not going to be good for you because it's already spread too much. So if it hasn't spread, then the surgeon will say, okay, this is what I can do for you. This is what the side effects would be. This is what surgery is going to be like. Don't make your decision now. You're going to go and talk to somebody called a clinical oncologist. So a clinical oncologist is somebody who does the other kind of treatments without a knife. So there are lots of different ways of treating prostate that are probably as effective in terms of saving your life and getting rid of the cancer, but have a completely different set of side effects that you might get. So the specialist the clinical oncologist will tell you, look, we could do this, we could do that. If we did this, it will give you this side effect. If you do that, it will give you that side effect. Unfortunately, you're left trying to make a decision. The only way you can make a decision is to think about, am I completely against surgery? Do I really not want a certain side effect for definite? Because every single treatment that we have so far ends up with some side effects, unfortunately. So you've kind of then got to make a decision as to what treatment you want. And there are different treatments, which obviously I can go through if we've got time, but it might be better to do the witnesses first. But does that answer it, or was there anything? You happy with that?
Right, I think to add to what Rob said is that we've got a gentleman sitting next to you. That's Brother Evans from Manchester South, and thank you for taking the time to come, because he now can actually give his experience, and then we'll have this gentleman here as well. Thank you.
Good evening, everyone. My experience in prostate cancer and the signs I've seen with it, why I go and get tests for it. I find myself was urinating too much. Sometime at nights, I'll get up all 5-6 times for the night. I said, what is happening to myself? Anyhow, I went to my GP, and I says to him, can I have a prostate cancer test? He said, yes, he'll take the blood. He take the blood and send it. When it come back, I ask him why. He says to me, I've got, what we call it, he's not really sure. But I says, I need to have a test. Again, He says, yes, he'll have a test with the blood again. So I says, no, I need to have a proper test about it. Well, he sent right away, he write a letter and send it off to Whittington Hospital. And 5 days after, I was called in and they take the test. You know, they have a finger test, which is a horrible thing I don't like. Didn't like it. But anyway, he says to me, your prostate is start to swell. It's swelling. So I said, what can you do about it? He said, right, I'll have to come back and speak with them. And you know, when I go to the surgeon, says to me, your prostate is swollen, and it could be cancerous as well. So I said, what can you do about it? He told me that he can give me chemotherapy, laser, tablets. And I said, what next? And he says, the operation. And I just told him and says, now what he says to me about, you know, my marriage life and things like that. I just turned to him and says, I have 4 children. And I won't be having any more because they're all grown-up children. So what you want to do? I said, I need to have the operation. And you know, I went home in the evening and I said to my family, my wife first, then call the children from the very house work and they come home. And when I tell them about the operation, they said, Dad, take the operation. So yes. I go for the operation, and from that day, that was from 2002, 24 years now, my PA has went up in 2005 in just around 0.4, and I go back to the doctor again. They send me to Christie's. When I go, Christy says they'll give me radiotherapy. And I have 22 radiotherapy. And it comes right back down to 0. And it's 24 years now, and until now, it's still 0. And I say, thank God. I say, thank God for his love towards me, because when I find myself urinating too much, I say, no, I'm not supposed to be like this. And I say, I have to get a test for it. And you know, this evening when I look at all the O's here, we find out it's mostly young men. And I'm going to encourage them, if any of them hasn't had a test, try and take it. Because prostate cancer is a very dangerous thing. I've got many friends who die with it. And with their argument about it, they don't want to lose their manhood. You know? And I'd rather keep my manhood than die. And thank God until to this day, I'm here. Tomorrow I'll be 90, I'll be 89. You know, and I say, thank God for my life and what he has done for me. So, yes, that's all I got to say. And encourage the younger men, if they don't have a test, as long as they reach 30. Because while I was in the hospital, there was a young man coming there to have an operation again, and he was just 29. So this thing can happen to anyone. So therefore, as I say, I encourage these men to have a test. You know, when Adrian talked about the NHS, I trust the NHS. And I love a lot of things that they have done. But I don't trust doctors very much. Because they're the one, if you go for a test They'll tell you get this and they'll tell you that. They want to put you off for what you want to do. So therefore, I don't trust them. Come back again. I had colon operation, which, because of the symptom, I went and get it. And he did try to put me off. Not the same GP. The younger man, his son actually. He tried to put me off it. Because when I have this pain in my tummy, it was so severe, but mostly at night. And I said, this thing, because I don't like pain, I don't like anything to happen to my body, to myself, but you know, when I find out they're happening, I say I got to look after them. And you know, I went for this test. My doctor says, is what indigestion. I'm in omeprazole tablets for my stomach for a long, long time, and he hope it. It didn't make a difference. So I go back and tell him I need to have a test. So I get on his computer at the same time and he write a letter and send to Churchthe. I was in my bed one Monday morning, early, around 8, 9 o'clock. My phone rang. When I pick it up, he said, this is Whittington, and I'm to come to Whittington immediately. I go, and the surgeon says to me, Mr. Evans, I saw something in your gut, just like that, like a big blubber. I said, what's that? He said something, and you got to go to operation right away. He said, I don't do the operation, but I have a good friend who will do it for you. And brethren, it's a good thing I go. When I get the operation, he says to me, you have cancer. And the cancer is just like my little fingernail. And he says, right, you're right to come and take it. So today, as I said, I'm here at my age, still living, still going around, do what I can able to do. So I thank Donald for asking me to come and to give my experience to each and every one of you. So as I say, any young men that are here, if they're over 30, make sure, try and get a test. Because prostate cancer is not a nice thing. Okay, that's all I have to say this evening.
Thank you very much, Mr. Evans. Very, very well appreciated. Wonderful testimony. Now, there's another testimony here, I believe, and then we're going to begin to round up.
Good evening, everybody. I'll try and summarize. You can see I have a smile on my face. But guess what? When you hear about prostate cancer, it's like, oh my God, oh my God. I want to assure you men and women who are here, if somebody tells you he's talking about prostate cancer, it's not a life sentence. All right, let's not be gloomy. The reason the doctor is here is to give us hope. My story, I was diagnosed with prostate cancer August 2022. We're just going for a walk. I didn't feel well. I went to the doctors. They said, get tested. Unfortunately, there was a locum doctor, not my usual doctor. So he went there. He looked at me. How old are you? He says, I told him. I was just under 60. So I looked at him and says, do you know about prostate cancer? Just look at me, guys. And I had no clue what prostate cancer was. Just look at me, how ignorant I was. He is a very well-learned guy from Africa, but he has no clue about prostate cancer. He has literally no clue about his health. So he talked to me through. That's why it's important to go to your GP and have a chat with your GP. So he talked me through. He says, because I'm quite an adventurous person. I'm not afraid to take risks. So he says, do you mind taking a test for prostate cancer? Have you ever had this? I said, no. He says, can I do it now? I said, yes. As my sister said, there was a lady there, a female doctor, trainee doctor in the room. Says, do you mind if she watches? And I said, no. The African part of me came in. I said, no. I just want you. So the lady trainee doctor was there, stayed out. And then he put his finger around, says, I don't feel anything. But because of your age and because of the statistics, as the doctor was explaining, he says, I'd like you to take a PSA test. I said, says, do you mind? I said, yeah, no problem. How do you do it? I didn't even know anything about the prostate, where it's positioned, what happens. I said, no problem. I'm an adventurous person. You must listen to my story as I'm talking. I'm also a man of God. I'm a preacher as well. So I said, fine, go ahead. He did the PSA test. He says, I'll give you the results. We'll give you a result later on. So fast forward. A week after, I got a call. I was driving back home. I live in Preston. I was driving from Bolton. The phone rings. I check, that's my doctor. I picked it up. It wasn't picked up, by the way. It was hands-free. Don't call the police. It was hands-free. So I picked up and says, oh, where are you, Fletcher? I said, I'm on my way home. He says, do you mind passing through the GP? I said, yeah, no problem. So I went straight instead of going home. Then he told me, says, oh, sorry, your PSA is a bit raised. It's 8.5. But it might be something, but it might be nothing. Then he talked me through again the chances of it being cancer. At the same time, he talked me through saying, it might not be cancer. But I'll give you 2 weeks. Let's see, come back after 2 weeks. Let's see how it is. That 2 weeks, I went on a holiday to Dublin with my wife, saw my son going to America. We came back. I didn't wait 2 weeks. 2 weeks was going to fall on a Sunday. So I went on a Friday. Went there. I said, no, the GP said to come back here. I need to do another PSA test. Oh, so fine. Fortunately, again, as God would do it, the same GP was there, a locum visiting doctor. He did the PSA test. This time, again, I was driving back home. He called. That was 2 days after that. He says, come in. I went in. He says, sorry, your PSA is raised. It's 9.5. It's not going down. It's going up. It might be nothing. Tell you what, these people, they're so reassuring when you sit with them. Meantime, he was telling me it's raised, but he was reassuring me. He said, might not be anything, but I need to refer you. Are you okay if I refer you? My sister was so lucky. Rather, I was so fortunate. He says, can I refer you? We need to do an MRI scan. I'd never been under an MRI scan. I'd never had a PSA scan or whatever. So he gave me a chance, referred me to the specialist. Excuse me. I went in there. I thought I was going to heaven. I lie down in there in that MRI scan. I thought, oh, I'm an astronaut today. Laying there, they did what they did. I was there, they did all the same. Wonderful ladies there as well. They did the bit. 4 days after, I got a call. This time I was home with my wife. They said, oh, are you okay to come to the hospital? I said yes. And this time, because I told my wife, and she's a medical person, and she's a medical person, so she realized. She says, what have they said? I said, I need to go and get my results. They said, we'll send them the post. I said, I'll come over. And at every point, I went with my wife. From that point on, I went with my wife. To the specialist, to the oncologist nurse, to the oncologist consultant, at every point. I said, come on, you got to come with me. She was willing, she came with me. So they said, yeah, we've seen something, but it might not be anything. We need to do a biopsy. Are you okay for a biopsy? I said, no problem. Go ahead, do it. And my wife looked at me and says, this guy. She didn't say anything. I said, fine, go ahead. They said, oh, we have to go to Churchthe. I went to Churchthe Hospital, Lancashire. They did a biopsy. That was a little bit uncomfortable, but don't worry, guys. It's going to lead you to the right route. They did that. The results came, and then they called me. Sat down in front with oncologist nurses, specialist nurses, and then, boom, sorry, the cells in your prostate have got cancer. Oh, then it sunk. I said, oh. They said, yeah, but here are the options, and then they talked me through everything else. My wife was sat right like the doctor sat here. They talked, do you have any questions? I said, no. So what am I going to do next? And then they walked me through the options of the treatments and everything else. They said, go home, think about it. I went home. I had nothing to think about. I didn't know what was happening. The only thing I knew is I've got cancer. I'm going to die. I was worried about my grandchildren. I have 4 lovely grandsons. And I was worried about my wife. I'm going to make this poor girl a widow when she's so young. Oh, my mother. And ironically, I must tell you, that was 4 months after they had buried my uncle, my mother's immediate young brother, who they are celebrating his life today. He had died from cancer. So I said, what am I going to do? Sat home, my mind went blank. Prayed. All I did, declare as a Christian, I said, God, I'm going to die, but I refuse to die from this disease. If I'm going to die, I'm going to die with this disease, but not from this disease. So fast forward, I went for treatment. First thing they did is I went to see the oncologist. They said, okay, there's either you go for radiotherapy, you go for surgery, or there's another one they're calling now brachytherapy. It's a nice name. It's quite nice. So I went over there. The surgeon said, Fletch, this is what we do with surgery. But looking at your prostate, the cancer is still inside the prostate. I wouldn't want to operate on you. The side effects are A, B, C, D. It might not be nice for you. I would recommend you go and see my colleague, another oncologist specialist who's specialized in radiotherapy. I went there, spoke with him. I told him, by the way, he said I was overweight. He didn't want to risk operating on me because my body weight was a little bit too much. He says, if you were below that, I would have done it because I'm the one who does it. Lovely Polish doctor. So we went to see, the following week, we went to see the radiotherapist guy. He sat there, lovely man again, spoke and explained what would happen, the side effects. That time there was a nurse as well, an oncology specialist. So we sat down and talked about it. I heard everything they said. And then they said, as the doctor said, and then they sent me back home and they said, now go think about it. What do you want to do? Which option? I was puzzled because I thought I came to the hospital, they were going to tell me how to treat me. But actually, they said, they threw it back to me, go make a decision. Which treatment do you want? If you want to go back to surgery, we shall operate on it. Do you want radiotherapy? Go to radiotherapy. And then the radiotherapy says, oh, by the way, I'll refer you to a friend of mine. I want you to consult as much as possible so that you have known. There's what is called brachytherapy. I'll refer you to a friend of mine. Fast forward, I came to the Churchthe here in Manchester, sat down with a specialist again, lovely doctor again, nice lady, explained what brachytherapy is, the options they had. Now I had 3 options. And the fourth one, my oncologist specialist said was, there's another one which is a trial. So you've got 4 here. And they gave me all the materials. Fletch, go home, read this. Once you've decided, this is a number, give me a call. But don't panic, go and read the materials. So I had 4 options to take. I was confused. I don't know any of these things. I don't know anyone else who has gone through this kind of thing. What am I going to? So we sat down, prayed with my wife. So what do I do now? Like I've told you, I've got 3 children. They're already grown up. I've got 4 grandchildren. So I said, side effects, looked at it. That's what worried me. Then I chose radiotherapy. I said, I don't want to have any more children anyway, so I'm going to go for radiotherapy. So I went over there, I told them I want radiotherapy, and then went over, spoke to them. I want to assure you, gentlemen, my brothers, my uncles, my cousins, my sons, it doesn't hurt to go there and get to know. There are teams of people that will look after you. I met a very nice specialist oncologist, a doctor, a female one, who sat down with me when I started radiotherapy. As the doctor was saying, such a boring thing. Every day you are going there for 15 minutes or 10 minutes, you lie down. You don't feel anything, then you're gone. The first thing she sat down and told me, says, Fletcher, don't worry about the cancer. We are going to take care of the cancer. These side effects are the ones you have to manage. You can manage this. So don't focus on the cancer. We'll take care of it. You look after the side effects because you will be doing. But these side effects, some of them will disappear within 6 months. Some will be there for 2 years. Some may never go. But you can manage them. But some of these side effects as well are treatable with tablets. If you want medicine, we shall give you medicines. Then I sat down She gave me so much hope. So I want to assure you, there are teams in our hospitals here who sit down with you and walk you through something. They will give you back hope. They give me back hope. I had my last PSA tests. By the way, that was just mid of June. It has gone down to 0.04. And they're calling it undetectable. So I have no cancer in my body now. So I'm encouraging you, I'm challenging you. As they've said, we must talk about this. I love what this church does here. They do life in this church. I've been here, this is I think the 4th time I'm coming here. They do life, they talk about things. When Elder Mackenzie called me, I was actually in Phoenix, Arizona. When he called me, it was midnight there. I said, yes, brother, I will be there. Because you guys, what you do in this church, you do life. And this is doing life, talking about real things in life. And he's given me a challenge, so I'm challenging you again. The more we talk about it, the more people get to know, the more we get our brothers. If we can save just one brother, one uncle, one son from being taken by this silent killer, we would have achieved something. And the only way we'll do that is we talk about it. And the second thing we have to do is go get tested, guys. It doesn't hurt. The PS test, you just put there, you know. Take a little blood there and you go back home. It doesn't hurt. Let's walk there. Let's go to a GP. Let's bother them. Let's knock on the door. If they say, I can't do a PSA test, I'm not going home. You know the African way. I'm not going home. You even take off your shoes. I'm staying here until you do my PSA test. Just do that. Let's go and do it. Next year, beginning of next year, I'm going to also host a similar one. I'm inviting you, Dr. Paul. I'm inviting you, sir, openly. All of you, come and join the guys in Lancashire. I'm going to host another talk show like this. We have to keep talking about prostate cancer among the black people. By the way, it's not only the blacks. My neighbor next door is very much like doctor. He's a white guy. He's only 2 years older than me. He's had surgery. So we sat down and started reflecting and talking about it. So it's every man. I'm hosting another one like this in Lancashire early January. So let's go. Here I am. Testimony. Like Uncle said, I've got my ears on again. It was 9. It was going up. Now it's 0.04. Amen. God bless you. And thank you very much for having me.
Thank you so much. It's really encouraging to hear real stories. Narratives of people's lives, and particularly, you know, that these have come from the outside to come here. We thank you both so much for that. Give them both one more hand, please. Thank you. And it's very encouraging. And then we have a doctor as well who's come, who's actually experienced something himself. So, you know, we're talking about real life. Now, as we round up, I'd like to thank you all for coming here, but I'd just like to just ask the doctor if there's anything else that you feel you need to say about Transform or anything like that, or in terms of encouraging us to not sit back.
Yeah, I mean, the Transform trial is going to be something which I think will hopefully give everybody the right way to go with screening and so on. And I'm hoping that we may, and this is just a may at the moment, be able to develop a system whereby there's a positive way of recruiting black men particularly, because I think we need those numbers, and that's something that I'm particularly pushing with when I speak to Sam, who's one of the organizers on Tuesday. He was very interested in this actually, and I'm going to give him a feedback as to how it went and so on. So I'm hoping it's been useful to you. So the Transform trial is something which is ongoing. I thought it was going to be a lot quicker than it was, but it's going to probably be another 3 or 4 years before we get the result of that. I think the important thing from today, which we've said again and again, is that you have your right to go and have your PSA test over the age of 45. And I suggest that you all have it every year. I didn't give you the position of prostate cancer at the beginning, which I was going to do, and that's prostate cancer is far and away the most common cancer in men. The only cancer that's slightly more common is breast cancer in women. So the two things are the most common cancers in the country. I think it's 57,000 women are diagnosed with breast cancer every year, and 56,000 men are diagnosed with prostate cancer every year. So it's that important, and we need to really just bear it in mind. But do your best to try and spread this amongst your friends and make sure that they happen. I'm just going to give you one little story, which Adrian is well aware of, because we have from school, we have a WhatsApp group. We call ourselves the Legends, Legends, we spell it. And we keep in contact that way. And one of our friends, so we're all the same age because we were all in similar years at school. So I was diagnosed with my cancer, and I obviously had told them. And I was saying, look, get your PSA test. Adrian, have yours done, which he has. John, one of the other lads, he hadn't had a PSA, and I was like, go and get your PSA. So he goes and has his PSA, and his doctor says, oh, it's probably just up a little bit because we'll test it again. So he's a lad that he used to go away to the rigs, so he goes away for weeks and then comes back. And I'm like, come on, John, you've got to get your PSA done. You've got to get it done. You know. So eventually, after much umming and ahhing, he gets it done, doesn't he? And he's positive. He had his surgery 2 months ago. So essentially, what's happened to me has saved his life because we made him do it. We said, come on, get it. We all have to get it done. And that's what, if we can all do that, if we can all encourage one person that you know to get a PSA that they haven't done, then we're going to find, from today, we're going to save 2 or 3 lives. I promise you.
Wow. Before I say my closing remarks, I think this brother wanted to say something just here, finally, and then I will say. While the microphone's coming to him, there should be some forms for you to comment on the program. Are they on the chairs, or they're coming out now? All right. Okay. Yes, sir.
Yeah. Maybe somebody's asked this question already. It's about getting yourself tested. Is there one test that's more accurate than the other? The finger test or the blood test?
The blood test is the one which probably is the most useful one. I think if you've got symptoms, then you need to have the finger test. So if you've got anything that suggests that you're not weeing as much as as fast as usual, or you're going more often than usual, you're having to get up at night 2 or 3 times, that would always be a sign that there's an issue with your waterworks, in which case you need the finger, because that gives you an immediate, the doctor can say, oh yeah, I feel something funny there, and it can speed things up. But in terms of screening without any symptoms at all, it's very unlikely that the doctor would find anything on the finger test if you're you're absolutely normal with your waterworks. But the blood test is really the only thing we have at the moment to screen and to just keep monitoring you. And having that done every year, definitely worth it.
Okay, so the second one is about, you talk about getting the test done yearly. Because for me, within my employer as a pastor, we have policy that at a certain age, you do once a year. After a certain age, it's twice. It's after every 2 years. A certain age you do after every 2 years. A certain age you do once a year. So it's policy. I don't know whether they've done research on this or not, but I keep on hearing you talking about doing it on a yearly basis, because I do mine's due well, it's during December. It's done bi-yearly, 2 years, after every 2 years. But that's according to policy. So I don't know if it needs to be revised, because I keep hearing you talking about every year. So, yeah.
Yeah, there's not a policy about the frequency at the minute. That's something that maybe the trial will work out. At the minute, it is simply left to your GP being told that they need to do it if you ask for it. I suspect if it's within a year, your doctor might say, well, I'd like to put that off till it's a year. But they can't refuse you every year.
Yeah. What I'm trying to say is, I'm talking about in my employ, as an employee, there's a policy that we have
Do
to
they
do
need to change it, are you asking?
after every 2 years. So I don't know if they need to change it, but
Yeah,
the policy
I mean,
says after every 2 years.
I spoke to a urologist about this once when I was playing golf with him. And he said if it was him, and that's what he's doing, is up to the age of 50, and he's a white guy, he would have it every 2 years, and then yearly after that. Because of the extra risk, I think that needs to bring down to 45 for black men. Definitely have it every year, not every 2 years. And I think that should be maybe something that your employer should change, because it's fairly clear. If you want to do something about that, I would suggest you point them to the Prostate Cancer UK website, because it clearly says that black men should be tested from 45.
Okay. We've really got to round up now. I would like to, first of all, thank Dr. Beardsell for agreeing to come here. Please, can we give him a big hand? Thank you very much. It's well appreciated. We'd like you to fill in these forms and pass them back to Donald Mackenzie, so that the feedback is always useful. And I think, Herma, you might want to talk to the doctor about a program at your church. But thank you all very much. And what's your name? Kirit. I'd like to thank you also very much for coming and taking the time. Really appreciate it. And bless you all. Thank you very much. And let's fight this thing. We fight it together. And let's take care. I'm going to pass over to Donald here now.
Right, I'd just like to thank these two gentlemen again also for presenting. As you can see, there's only a few of us here. We did a huge canvas out there, reaching out on the radio, barbershops, WhatsApp. We even actually did all the way around this community, and you can see how many people have actually turned up for this important thing. So what we're just encouraging is get the word out. I think also, I know that Keith has been doing something, you've been doing a great ministry as well, is that, we men still need to come together and discuss about this. Because oftentimes we talk about so many different things, but things that can save your life. So I'm just encouraging everyone that, what you've heard is your brothers, your uncles, your dads, is talk to them about this and get the word out. At this moment, we're just going to close in prayer, but just continue just filling in those survey, because it's important that we can do further outreach. What we've done, we've got some little light snacks outside, just that, if people still want to talk and just have a little bit of conversation as men, and I know ladies are here as well, is that we just, if people want to hang around for maybe 10, 15 minutes, just help yourself to a few snacks out there, and if you want to continue that conversation. But a big thank you again. And as I said, let's get that word out there. And I want to thank those that are on Zoom as well. I hope that you've learned something from this also. So shall we just bow our heads in prayer? And Father, Lord, we thank you for this message on health. Lord, you've given us the knowledge. You've given us everything that we need, that we can look after our bodies, that we can realize, dear Lord, it's so important not to just realize that sometimes when things are developing that we just put it aside. But help us to realize, dear Lord, that even as we've heard this message, we need to also remember that it's not about us also, but it's also about our families, our loved ones. I pray, dear Lord, that what we've learned, that we may reach out to fellow men, and that the experience, Lord, the words that we've heard, that may not fall in on deaf ears. But we pray, dear Lord, that what we can do with the knowledge that we have, that may benefit many others, we pray. In Jesus' name. And be with those, Lord, that have traveled a distance, that you may give them traveling mercies also, we ask. Amen. Amen.